This webinar is co-sponsored by the New York chapter of the American College of Physicians, NYACP, and NYMDA, the New York Medical Directors Association. And we are very delighted to have Dr. Thomas Wong present on approaching adverse events with root cause analysis thinking. And we were speaking before this, and we were saying how really there's so many things in life, not just medicine, there's so many things in life that we need to know how to think about to figure out what the root cause was so we could actually, make true change. Go ahead. So a little bit about NYACP. NYACP is the largest medical specialty organization in the state. It advances a specialty of internal medicine through the state and focusing on internists as well as the subspecialties, working on education, adequacy, and quality improvement. It represents over 12,000 internal medicine physicians. And go ahead. And NYACP has several upcoming events. Actually, we're missing the one that's tomorrow. So tomorrow night, stop the presses. We're having the first Elder Abuse series. If you haven't registered for that, please do so. And then the second part will be March 19th. And then there's some Women in Medicine series as well. NYACP is having their annual meeting in 2024 in the fall in Tarrytown, New York. And if you have anything to submit, the abstracts are being accepted. And there's also a Doctor's Dilemma, which is a fun competition. So you can check those out. If you didn't scan fast enough, you could look for it online. What is NYMDA? So just back up for a second. It's a little bit like when you have like your high school friends get together with your college friends. You're like, will they get along? But they do, because they're all your friends. So I should say for myself, I am the chair of the geriatrics task force for the NYACP, and I got my GED. I'm the governor-elect designee for Long Island, meaning in April I become the governor-elect, and then a year later I become the governor-elect of NYACP. And I also want to speak about NYMDA. So NYMDA is the New York Medical Directors Association. It's basically the state organization for nursing home physicians and really medical directors, and it's the state chapter of AMDA, and also provides education adequacy. Oh, I can't click. You have to click. Sorry. No power. So NYMDA focuses on medical directors in nursing homes. There's a new organization called the New York Society for Post-Acute and Long-Term Care, NYSPAL-TC. I am actually the president of both of NYMDA, and I'm also the president of NYSPAL-TC. And so NYMDA and NYSPAL-TC are together organizing a spring education meeting. It's in Albany, and so you can, QR click and or go to the webpage and find out more. So that's how we got to this point, and we're so grateful to this point. I'd like to introduce Dr. Thomas Wong. He's a senior physician in the Office of Healthcare Inspections within the VA Office of Inspector General. He's cared for veterans as a primary care physician, for 13 years in the Finger Lakes. There's no way I am trying to say that while being recorded. No way. In part of the VA. He's board certified in internal medicine, and he's actually, despite, or in addition to his work with the healthcare inspections, he's an active clinical practitioner as a volunteer physician and medical director at a clinic in Rochester, New York. Go ahead. The planning committee has no disclosures. I guess that's one of the benefits of geriatrics. You don't get paid a lot because there's not a lot of drugs. Next slide. This is a list of the planning committee. We thank everyone for their contributions and support. And this is any disclosures that the planning committee has. This course, this 1 hour presentation, you can get a credit of CME. You can also get MOC for those of you who need it. Just remember, you need to answer the questions to get the MOC. You can go to the next slide briefly. There will be, you can click again. There will be a QR code available at the end of the course, and that's where you get your CME credit. And if you want to find out more about any more ACP programs, please check out the Learning Center. So the only thing I'll ask is, I think everyone is muted. Dr. Wong is going to share his screen. If you have a burning, urgent question, go ahead, click raise your hand, and you can unmute and ask your question. Otherwise, we'll try to save the questions for the end. All right, thank you so much for everyone for being here.
Thanks, Dr. Lester. How's everything in the screen? So you could see everything okay and hear me okay?
Yes, it's perfect.
Okay, great. Huh. Well, thanks for inviting me to talk about RCAs, root cause analysis, and the thinking. Uh, so first of all, it's really not lost on me how difficult your jobs are. You take care of people probably in the most fragile, least resilient, and often the sickest time in their lives. And on top of that, you have an environment that's really highly regulated. So I think back at my years in VA healthcare, which is can be a harsh system, but on top of that, what you have are regulations, but what else you have are resource constraints. So that adds certainly a layer of complexity that makes it difficult to protect patients. So this topic today is really about root cause analysis, and it I'm sure you're familiar with adverse events and looking at adverse events, uh, and probably have gone through some root cause analysis teams or training. So if you know about this, I hope it's a good reminder as well. So nothing to disclose. I have no financial relationships, no relevant non-financial conflicts of interest. And certainly the presentation today doesn't reflect the thoughts of the Department of Veterans Affairs Office of Inspector General. What I can say though is that we train our inspectors in a certain way to approach adverse events, and how these adverse events are looked at is through a root cause type of thinking. And when we inspect hospitals across the United States, VA hospitals, uh, that type of thinking and that type of adverse event analysis is expected when they give us an RCA. We want quality RCA products. So that's the kind of thing that I'd like to impart on you today. It's not more about the mechanisms of doing an RCA. It's more about the RCA thinking process in itself. So I'll use hospitals loosely. I mean, we have about 140 VA hospitals across the United States, but over 1,000 outpatient clinics, and about 130 long-term care facilities. So when I use hospital, it's pretty loose. So our objectives today for approaching our root cause analysis thinking, really, I like to discuss what RCAs are about, discuss how RCAs are reflective of high reliability organizations, which you may be part of or may be hearing a lot about, and then discuss the steps in performing an RCA and how it can apply to analyzing most adverse events that we encounter. And then what makes a high quality RCA? So what are the elements of a high quality RCA? Hard to talk about adverse events and patient safety without having this hallmark of a publication from the Institute of Medicine in 1999, To Err is Human, which noted 44 to 98,000 deaths were from medical errors, meaning that it was at that time the eighth leading cause of death in America. It's even recently there's been more publications that really looks at it, and some even say it's the third leading cause. And there's probably a lot of debate about that, but the fact is that it's high up there still in terms of uh, morbidity and mortality. So out of that came a lot of traction, and the traction of a patient safety movement, which continues today, looking at all these things that I'm listing here, and you can certainly read about, and some directly affecting you probably day to day as far as your care for your patients. But the list is tremendous. Incidentally, around this time of 1999, there wasn't a vast amount of electronic health records yet, but there was the movement of collecting data. And the collection of data coincided with the computer systems that were more robust, and with all this data came a lot of diagnoses, secondary diagnoses. How can we use this data to improve healthcare? It was no coincidence that this was about the time that a lot of things were starting to be analyzed. Uh, and it and to analyze this, you had to have a mechanism. You had to have a predictable mechanism to say, you know, we're going to look at it in a certain way. We're going to have a systematic way of funneling through certain events. So not all events, but certain category of events. And that's where root cause analysis in the healthcare field uh, started to take traction. So some of these goals. So the RCA, it is a structured method used to analyze serious events. So the objective is to provide actions that will prevent similar events in the future, hoping that we can build just a safety culture instead of always blaming, say this happened because of this person, this employee, this staff member. And the goals is of that team to look at these events, is to evaluate what the event that happened, the reasons why this event happened, propose the actions that fix the issues, and then measure those actions to ensure success. So the upshot is run certain adverse events through a particular program, apply it in the same way and analyze it in a very similar way, set the expectations of the fixes, and then set the expectations of the outcomes of those proposed fixes. And it's also important to note, in the federal system, at least, the RCAs fall under quality assurance where it's not discoverable. For non-federal, it really is a state-to-state decision, and most states do protect RCAs from discovery. There's been a couple of cases that have come out recently that challenge that, but in general, we've been afforded that a patient that says wants a malpractice lawsuit, the RCA event is really not discoverable. You can see how valuable it could be if it was discoverable to a plaintiff for malpractice. So we have a lot of industries actually that use root cause analysis, everything from manufacturing, aerospace, other government agencies, the FAA, the NTSB, they all use this method, but there's a commonality to this. And really it is about getting to a particular point, the point of say, a product or an end result. So in our case, for healthcare, it is about safer patient outcomes. For those patients who are subjected to a particular issue in the healthcare environment. So you might be saying, well, you might be looking at, well, aren't you looking at things to make the efficiency better? And I think in manufacturing and in the many places, efficiency is about is related to safety. In healthcare, we can't think of it that way, and it's the reason is that if there are too many steps, uh, and those steps can lead to failure in healthcare, then yes, making it more efficient is the way to go. But healthcare is not like that in that sense, because those steps sometimes are actually steps that saves lives and that are meant to be there. So efficiency is not always related to safety. And the analogy that I use always is I can drive to the grocery store at 100 miles an hour and be very efficient, but not necessarily safe. So a word about high reliability. So you may have heard about many high reliability principles. So several, right? Preoccupation with failure. So an organization that keeps thinking that their processes are not safe, even the established ones, and they can fail. That's their preoccupation with failure. The reluctance to simplify interpretation. Simple adverse events, simple things that look simple, might be a symptom of an underlying problem that really is in the system that may need to be corrected. The sensitivity to operations really is about paying attention to what others are talking about, what the frontline staff are talking about. Understanding the problems that you have in one area of your healthcare system may affect other areas as well. The commitment to resilience, pretty self-explanatory. When certainly COVID hit, that really tested the health system to bounce back. And then deference to expertise. Those who know are really those who know the system and work the system and have to deal with the system. And again, it goes back to many staff that are frontline that understand this. Joint Commission, the best way that I saw how Joint Commission looked at it is a quote they gave. So when we look at root cause analysis, there's a level of detail that's incorporated in reports from organizations that are farther along on the high reliability journey. You know, these organizations recognize the importance of receiving input from frontline staff who can speak to the workflow. So getting away from broad analysis that are often ambiguous, policies that are often not really clear, and to have greater specificity to the problem from those who work at it day to day. And I think that was a good summary. But everybody agrees in principle to high reliability. Nobody that we interview in all the hospitals that we enter and all the long-term care facilities that we examine in VA disagrees about high reliability. So when we interview folks, you know, these kind of questions are almost like you know the answer to what's going to be said. I think what's important is to look at what they consider as the healthcare system facility specific quality indicators. What do they consider as important beyond what the regulatory bodies actually are wanting? And I know you have to focus on certain things and certain measures and all the things that you're judged on. But beyond that, what is there? So looking at your own data, their own data, looking at tort claims, that's what we do. We ask for tort claims. We ask for tort claims not because we want to find out the worst of the worst. We want to find out, based on any trends in the tort claims, what have you done as far as protecting yourself and your patients from similar events in the future, and what have you learned? Same thing from patient advocate reports, and we trend out certain departments and certain areas. We certainly look at peer review trends and specifically looking for, is peer review looking beyond the provider, are they identifying system issues? So it's really what I'm saying is the actions that really speak more than anybody or any medical director or any chief of staff will tell us. If we look for certain measures and how they're doing, and if they are of the understanding that they need to look at processes differently and in a safer way, that probably is more indicative of high reliability. So if you remember root cause analysis and the analogy, Swiss cheese is always the analogy. And I think if you will remember the Swiss cheese analogy, you'll forever remember root cause analysis and adverse events and how to approach it. So a block of Swiss cheese, if you slice it, the holes will never line up. If you shine a flashlight from one end to the other, you won't see the flashlight on the other end. So those slices are actually your protective mechanisms of something about to go wrong. So an event that goes from beginning of the arrow, and if it makes its way to the end of the Swiss cheese, bad event has happened. The holes are the defenses that basically failed because if there was a plugged up hole, that mechanism actually stopped the bad event from perpetuating, from moving on. So that's the Swiss cheese analogy of a root cause analysis. And what we don't want to see is this straight arrow, all the holes. But if you think about some of your adverse events that you've seen, things have to line up. Things have to fail. Staff have to stay quiet and not voice that something's wrong. All these mechanisms that are meant to protect patients have failed if the holes line up and the arrow is allowed to move to the other side. New York Times did a good article of when the COVID hit about that Swiss cheese and all these layers of protective mechanisms that should occur, masking and vaccinations and social distancing and all of it. The other side basically was catching COVID. So I thought it was a good way to present it to the average reader as well. So I'm going to talk a little bit about looking at severity. So the severity of an issue, we categorize this into 4 categories, and this is mainly for our patient safety officers in VA that need to look at problems in a certain way, and you'll understand in a couple of slides. So why we ask them to do it this way. So catastrophic is something quite easy to understand, and minor is very easy to understand. So it's mainly between a major severity and a moderate that we have to kind of recognize that, oh, what is major and what is moderate. So if you look at it, catastrophic's death, minor is no injury at all. Major would be about some surgical intervention or disfigurement or increased length of stay for a few patients, versus moderate would be like an increased length of stay for 1 or 2 patients. So kind of guidelines to kind of say how severe is this event. And then we ask them to say, well, what's the probability of this event happening again? So, or happens, so, if there's a trend. So if it happens frequently, what does that mean? I mean, that really means like it's several times in a year. Occasionally 1 to 2 times a year, uncommon 2 to 5 times a year, 1 time in 2 to 5 years. And then remote, which is really unlikely to occur. So with that, so with the severity and with the probability, we ask our patient safety officers to apply that into a matrix, into something called a SAC score, a safety assessment code. So what's the probability and severity? So if it was already catastrophic, it's automatically a 3. If it's something that's extremely frequent, but major, it is still a 3. But if it's very frequent but it's minor, then it's a 1. So what is this matrix about? There are certain requirements in the VA healthcare system that requires a facility to do an RCA, and that is a SAC score generally of a 3. So they can always do it with other SAC scores, but it's a requirement that all 3s that are SAC'd out have an RCA completed. So it's not more about saying you should do it this way, but thinking about it, I think helps. I say, well, how severe is this? Or is this my fifth hip fracture in a month? That might really cause you to say, well, maybe we shouldn't go through the same channels as we did previously, and maybe an RCA would be indicated at this time. So some of the steps we'll talk about as far as doing an RCA. So step 1 is really to get a team together. 4 to 6 members, I think that is a good amount of folks, and they could be subject matter experts. That you do need a leader, you do need an advisor or a leader. I think the most important part is that it's good to have a facilitator that's familiar with and experienced in RCAs to kind of guide the team into thinking in RCA terms, into just not if they're going astray and into non-RCA thinking. Those with experience and those that are trained in RCAs would be good to have. So it's always good to have somebody on the team that has that expertise. Usually the patient safety officer in VA has the training. We usually expect them to go to a week's worth of root cause analysis and patient safety training. About 2 days actually is devoted to RCA training in that week. And then non-subject matter experts. So that's always good too. You don't want people that know everything already about an event. The other part that's also important is to not have people that are directly involved in the event to be on the RCA team. That really really affects the integrity of the objectiveness of what an RCA team should be looking at, and certainly use them for interviews because they're going to give good insight, hopefully, but they should not be included in the RCA team. It is it's almost a thing not to do because they may come very much so with a lot of subjectivity. Next, step 2 really is to conduct. Most of the time these new teams don't have much training. So there is a video on the National Center for Patient Safety VA website. And it talks about RCAs. It goes through a sample case really quickly with them, and it's called just-in-time training. So that's gathering the team together. And then really you get to the nitty-gritty of step 3. Step 3 is about looking at the timeline. Every single event and we've seen hundreds and thousands of adverse events come through our place. Every single event has a timeline. There's always clarity in constructing this timeline, because what happens is that when you construct a timeline, you're putting down what your knowledge is of what happened, and your knowledge of what happened or the team's knowledge are you'll have a lot of missing elements. And those missing elements are basically the questions that come up. Sometimes very important, sometimes not important. Sometimes they're actually the root causes of things. So your timeline of an event is always going to be your friend. Every medication error has a timeline. Every fall has a timeline, and every order that's not acted upon has a timeline. And same thing. Think back to the Swiss cheese analogy. That is a timeline kind of event. So this is just a sample from the VA patient safety website. So during the first time out, the nurse stated that the last four of the patient's social security did not match the last four digits written on the implant worksheet. So the procedure continued, and the implant was done. As the surgeon started charting, and then he realized that was the wrong implant that was inserted. So the surgeon requested the patient be re-prepped and draped, and then the incorrect implant was removed, and the correct implant was inserted. So these are the sequence of events that happen, and you'll probably think there's a lot wrong here, with these procedures, the timeout policies, the stop the line or speak up when you see something not right, all the way down drilling to a culture of were people afraid to speak up in the operating room, and what were the mechanisms that would have protected the patient, or that were there, but that didn't work to protect the patient from getting the wrong implant. So that's the significance of a timeline, is that it makes you question many things that occurred within those boxes and in between those boxes and the arrows. So the step 4 is really the crafty understanding. So once you get to that level, you're going to look at certain things. So you're going to look at staffing, equipment, the environment. You'll have a lot of these kind of categories to look at, and then you're going to ask why. Why did it happen? Why was this procedure allowed to progress? And invariably, you're going to be identifying policies. You're going to be identifying protocols, and that may or may not have been used. So this is from CMS. Again, a sample. It's a timeline. They have a timeline of CNAs getting a Hoyer lift and positioning it by the resident's bed. So the resident is raised from their wheelchair using the Hoyer lift. The CNAs swing the resident towards the bed. The lift starts to collapse and tips to one side, and the resident drops to the ground, and the lift falls on the resident. So again, a lot of questions should be coming into your head, like, okay, why did this fail? Is it an equipment failure? Is it a failure of not recognizing the limits of the equipment? What particular procedures should the CNAs be doing before placing the patient on this Hoyer lift? So lots of questions come up from a timeline. So they did list things. So contributing factors. So CNAs had to hurry to find a lift so the resident would not be kept waiting. And the facility's one heavy-duty lift was being used in another location for this particular slice of the timeline. And then down where CNA swing residents towards the bed, the resident was moved rapidly towards the bed because the lift arm started to slip. And then the CNAs were not trained to respond to lift malfunctions. So lots of critiquing here as far as what went wrong, and to really look at it. Now, contributing factors are not root causes. They contribute to the event. And how do you know whether this contributing factor is just a contributing factor and not a root cause? If you can ask another why, it's unlikely that you got to the root cause. So there's no sign here. It says no sign on lift indicating weight limit. Yeah, that's true. Nobody put a label on it. But why was that? Why didn't nobody put a label on something that should have a label to specify there's a limit here? Did the label fall off? Was there never a label policy on Hoyer lifts? You know, these are the things to investigate that will get you to the root cause. But time and time again, we do see teams stopping kind of at the contributing factors level and just saying this was the root cause. And that's how we critique adverse events. It's asking ourselves, can I ask another why? And am I satisfied with this with the answer to this why? So step 5, really identifying the information gaps. So you determine the missing information, gather data, even visit the site, and certainly we tell our folks to if possible simulate the event. So causalities, right? So causes are many for root causes, but they mostly fall under these categories. There's the human factors of communication, training, fatigue. I'm sure you've seen this, where the communication is probably the #1 issue for many things. It's failure to communicate. It's communicating the wrong information, and certainly training is part of it. The environment. The environment, is it a safe environment? And that falls is very common to look at the environment. The equipment, such as the Hoyer lift. Rules and policies and procedures. Were they there? Were they not there? Both are equally good to critique. Policies that are there but fail often are because those policies are really not good. And staff are actually circumventing policies so that they can get their work done. So we look at policies really differently. If it's there and it did work, that's great. But it seems to be a big root cause of failures for many things in policies that are either very vague or not written well, or left for staff to interpret. And then barriers. And what we mean by barriers here is those protective barriers that fail. So if I ordered a drug that was to be given, through the IV, why could this drug be given intrathecally? those two don't match, but there have been errors like that. The answer is that they should never match, and something given intrathecally should not fit into a device given through the IV. Same things as mixtures of gases. There's oxygen, there's nitrogen that anesthesia uses. Those fitments in the gas fixtures, they don't fit. A nitrogen fitting doesn't fit an oxygen fitting, so it prevents that physical barrier prevents an issue from going on. Some of the rules for root causes, and these are really, really 5 important rules in writing a root cause. It has to show cause and effect. So a cause and effect really is what you're really, really looking for. So the provider ordered the wrong drug that caused an adverse reaction. Number one, it isn't really specific. Number two, does it really get to the root cause, like the provider just ordering the wrong drug? And in times before, that was a good enough answer, and that was it. The provider would get re-education. But if it was a deeper issue than that, right? So that's what we want to know. Like, why did the provider order the wrong drug? And we have to be specific about it. So the computer system showed an incomplete drug name on a non-maximized screen, resulting in the provider choosing Depromedrol versus Depo-Provera. Provided the opportunity for the provider to order the wrong drug. So it has to be very specific. And that's what you need in a root cause statement is to have something so specific that everybody understands what went wrong. And then that's actually something that has happened in some computer systems, is that as the provider types in DEPO, they'll because they're they're in alphabetical order, and Depo-Provera is second to Depromedrol, but the provider chooses Depromedrol and inadvertently gives that instead of the intended birth control. So these kind of errors really have to be looked at. Human errors, they have a preceding cause. You just can't say that it was a human error and that's it. They always have a preceding cause. Violations of policy are not root causes. And that's really true. So blaming a policy in itself contributes to an issue. But to say that staff did not follow policy, or that but the policy didn't help with this problem and caused it, that really needs to be avoided. And the failure to act is only causal when there's a pre-existing duty to act. And that's pretty self-explanatory. So these are the 5 rules of root cause statements. So we can't say, due to a policy failure, this happened. So what are the stronger actions? Once you know the root cause, and once the team develops these root cause statements, the strongest actions are about changing the physical space. There's really very little that's stronger than actually changing the physical space or the equipment, if that was an issue. I think back at the original ways that we used to brake and reverse in cars. If you think about it, you must have your foot on the brake in order to change the gear into reverse. That's almost a given. Not long, not years ago, actually. You could actually just reverse it into reverse without engaging. So that's called a force function. And a force function is I'm forcing you to do something so that you can engage something else. So that's an engineering physical change that really is a very, very strong action. Of cars just don't go into reverse anymore because of that. They don't go inadvertently into reverse. So those are the control mechanisms. Simplifying processes. Again, if I needed 10 steps to do something, but I can do it in 5 steps, I'm eliminating then 5 steps that may cause error and may cause failure. So removing unnecessary steps is important if they're unnecessary. Um, Standardizing equipment protocols. These are about standardizing operating procedures. And before we start on this, we're going to check this. Aviation industry, really important to do checklists before a flight. You know, however many times they do it, it has to be done at every single flight, so that this checklist helps them in this protocol to get things done. So order sets are here. So you may have seen lots of it now, and that's based on a safety study that was done with standardized order sets, so there's little deviation. High reliability and culture change. So very, very easier said than done with culture change. So intermediate actions. So some of the intermediate actions is about redundancy. Let's have another way to do this, another double check mechanism. A checklist is there as an intermediate. It's a reminder to remember to do this. That means training with simulation, not just training in itself, but training in a simulated environment. And then the weak actions are the double check mechanisms, the labels. How often have we seen labels that on medicines and but still the medication error still occurs? And if you notice here, policy, weaker actions as far as changing policy, and that's often a leader's response is that something bad happened, so we're going to change policy, and but we do see the same issues happen again even after policy changes. Training is always one of those. Okay, well, they weren't trained enough, so we'll train. If you notice, this is a weaker action. So assessing outcomes, you think about implementing this, and were your leaders, the ones you proposed, certain recommendations, did they listen to those recommendations, and were they fully supportive of those actions that the team felt needed corrected? The compliance, so were staff compliant to these new changes? And then the impact. Did the change make a difference? And I think that's the assessment of the outcome, is that you would want a metric. You just can't say, we found this, we made recommendations, and we're not going to measure it. It has to be measured, because how do you know what you changed resulted in an improvement? So just some warning signs of not great root causes, no contributing factors. Well, if you don't have a contributing factor, then that root cause analysis really failed. blaming is another one, and that's pretty basic, but we still see that as far as sometimes coming out of RCAs, it was because of a staff member. If you see that there's only weak or intermediate action, there's nothing strong in the recommendations, that's another warning sign. So the rules of causation, they weren't consistent with the 5 rules. So nothing to correct. So therefore we're okay. So that's again something we see. There's in an event that's adverse. There's usually always a correctable action. And then the follow-up's important. When they're assigned to groups or committees and not to an individual, that accountability piece is just not there, and it ends up often not being implemented well. And then there's no completion date. There's no well, the end date is well, we'll keep it open. That's a sign that it might not be a good analysis. We use 45 days. We have a clicker where once the RCA is identified, the team has 45 days to complete the RCA and present it to leadership. So, and of course, if around you there's little confidence that things will make a difference, that's something to be wary of. So just RCA tips, right? We said those involved directly in the adverse event should not be on the RCA. So accuracy is in the timeline is required. If you're going to use the timeline as your anchor, then that RCA timeline is extremely important. And personal recollections, interviews to get this timeline, it's always suspect. If you can get it from documentation, it would be much better. And certainly if they're based on just a hypothesis, yeah, and certainly involved. If there is not involvement of frontline staff and hospital leadership, then an RCA is not likely to be worthwhile. And certainly focus on the cause and not the problem. And evaluate every reason why a particular root cause may not be accurate. And evaluate every reason why a particular action to remedy a root cause may not work. So there's that vetting process of what you're recommending, and certainly measure. And if it fails, that's okay, but figure out why it failed, why those recommendations really were not weren't good, and tracking those measures from individual that were responsible. This is pretty much the last slide. Don't get hooked on those definitions. What I really wanted to present here is just a way of thinking. When you're implementing recommendations, who gets the those recommendations? Who does it affect? And who's responsible for them? So that's this article talking about the scope, the breadth, the depth, and the degree. Is it a sea change for everyone? So is this degree of recommendations or going to change the way we do business every day? Or is it very confined to a very tiny area, to very few people? These are some things to think about in the root cause outcomes. So you have here a lot of things that you've been exposed to: transitions of care with communication failures, falls, medication errors, pressure ulcers, transition of care, failure to provide care. Use these opportunities to really look and see whether a root cause analysis might really help. And I think there's so many opportunities in our healthcare system to have a look over with a root cause analysis. Yes, and access to testing. And in the world you live in, resources are scarce and it's not always accessible. But that sometimes deserves a look as well. So really my ending remarks is, you are the thought leaders. You take care of patients every day, and staff count on you to look at things in a different way. And in that way, they'll follow through. I mean, they'll often think in the same critical way that you start to think and you think as well. But in the end, it is about the patient and the safety of the patients when we do a root cause analysis. So that's, I think, all I got. These are the resources basically that were used. So much of the RCAs really stem from the National Center for Patient Safety. That's the where even private sectors learn how to do RCAs, especially in healthcare. So that is the industry standard, is that they have been doing this for the 20-year duration. Well, 1999 since 2000. All good. So let's see, any questions?
Thank you so much. That was great. So I really like the idea of, like, getting, if you could ask more questions, why. I remember when my son broke the iPad, there were a lot of questions why, and, oh, it fell, why? And, oh, I shouldn't have been running with it while flipping it open while trying to turn on my thing. And so, yes, so that was fun. I have a question though. Some of these seem easier to fix. Like, you could put a label on the Hoyer lift. You could get only heavy duty Hoyer lifts. But in the surgery case where someone didn't feel comfortable saying explicitly, this is the wrong patient, when you literally have a timeout for which that purpose is, like, how do you fix that?
Absolutely. And that's the hard one, because that looks into the culture. It looks into the practices of just, quite frankly, bullying in the operating room, where staff feel intimidated for that. I think you have to really interview staff, and that's where the interviews are very helpful for those that were involved. The RCA teams basically will will interview the surgeon, we'll interview the staff people, see which if you'll get probably different answers from them. But I think that the culture of safety, if it's not there, that is the root cause. I mean, for that. You can have these timeouts, and these timeouts are supposed to be there for a reason. And obviously, it failed in that instance. If that was indeed the root cause. So interviewing staff and just deploying recommendations that really don't even involve the surgeon, involves the operating room staff, to automatically just go down a path of safety. I think that's one of the ways. But you hit the nail on the head with it's the culture. And we still see huge amounts of bullying, and probably over 30% of our inspections, there's that issue that comes up. It's the psychological safety, basically. And when patients don't feel when staff don't feel psychologically safe, they won't speak up. They'll notice something. They'll they won't stop. They won't say stop. Um, and worst of all, they won't communicate with the person that's in the room with bullying. So it's psychological safety is a huge thing.
I never thought of it as safety and as bullying, but it kind of is, right? You're afraid to say something because something bad's going to happen to you. Hold on, I see a chat. So on the chat is the links. You can click the link for your CME. You can click the link to register for tomorrow's elder abuse and look for other events, or you could use the phone to scan the QR code there for your link. This is great. It really, this is really kind of so applicable across, across all aspects of life. Needless to say, my son did not get a new iPad. He had the choice of buying himself one or not having one, and he decided not to have one. Someone asked if the slides could be shared. Is that okay with you? Okay.
Oh yeah, absolutely, absolutely. And you can share my email as well. I'm happy to answer things and all. It's great, So I work with other federal agencies. I've worked with the Peace Corps, with the State Department, and looking at their quality processes. But it's great to extend it to the private sector. Really, it's a good thing. This patient safety movement. It's still ongoing. It's taken so long to get some traction, but I think it really has changed quite a bit. I mean, if you think about it, so I trained in those times where there wasn't really that kind of movement, and uh, so I would say patients are safer. I mean, now than they were like 10, 20 years ago.
I agree, and I think that it's almost like a culture shift. That it's okay to say I made a mistake. It's okay to say you made a mistake. It's okay, and most importantly, it's okay to say, all right, this is what happened. What can we learn from it? How can we fix it? And
Yep.
it's kind of like the things you should learn in kindergarten, but you don't. So
Absolutely. Interestingly, we have nursing homes and long-term care facilities in VA, and there's a lot of hip fractures that happens. And every hip fracture, the medical center director is supposed to do something called an institutional disclosure, where they say, it was on our watch that the hip fracture occurred. And we're going to look at it, we're going to investigate it, and but we just want you to know we're sorry that this happened. We're going to review it. And the other part of the institutional disclosure is here are the tort papers if you want to file. Yeah, that's an odd thing that I had to get used to, but that's and oddly there's not a lot of tort claims for those hip fractures, but it's trying to be transparent and be very much inclusive of the family that are affected from that.
it's true. It's true. I remember when I was a kid, my grandmother, if I made a mistake or did something wrong, she would say, like, listen, everyone makes mistakes, but how are you going to learn from it? Like, what are you going to do differently? So
Sure.
that's kind of on a much broader scale. So she did good.
Oh.
All right. Well, again, thank you so much, Dr. Wong. This was fantastic. Thank you, everyone, for joining. Please look for more NYSPLTC and NYMDA and NYACP events, and please keep doing good. And if you, it's the New York City logo, right? If you see something, say something. I guess it applies to a lot of places. So thank you again. Have a great night, everyone.
Thanks, everyone.